All right, good morning, everybody. My name is Mary Leonard. I'm chair of the Department of Pediatrics, and it is my great pleasure to welcome you to Grand Rounds this morning. And as I mentioned last week, today's Grand Rounds is a very special one that is a long time coming, and you will hear more about that in a moment. But before we get started, I want to make sure everybody has the information they need on the left to get your CME and MOC credit. And then also want to call your attention to really outstanding lineup for the next couple of weeks. We're going to hear about psychological considerations across the lifespan of congenital heart disease. And then very important, we have Thomas Lee from Press Ganey. And that's going to be a very interesting conversation about building trust and social capital during a time of turmoil. And that's our patient safety lecture sponsored by Grace Lee and our Chief Quality Officer. So really a really exciting lineup here. Next slide. We will do our university land acknowledgement. So we're always so pleased to be back here in person. And for those who are upstairs on Zoom, you can still run down and come in person. We are serving breakfast, plenty of food. But we recognize that Stanford sits on the ancestral land of the Mwekma Ohlone tribe. This land was and continues to be of great importance to the Ohlone people. Consistent with our values of community inclusion, we have a responsibility to acknowledge, honor, and make visible the university's relationship to Native peoples. Next slide. All right, we are in the home stretch. The wellness survey deadline is tonight. I hope you all know that we're competitive and we're neck and neck. As of last night, we were just the second highest department in the entire School of Medicine for our completion rate, behind a very small department. So I want everybody to jump in and complete the survey, but much more importantly, I just want you to know how much we value the information that we get from this strictly confidential survey. It really informs a great deal of the work that we do within the Department of Pediatrics. So I hope you all know about the Stanford Medicine doctor survey run by Tate Schoenfeld in the well-being office. And the results really do, we get all sorts of comparisons. We get our department compared to other departments, within the department, division versus division, but much more importantly, within divisions, we can look at changes over time. And that's really the power of this survey, and really relies on a high response rate, because looking at change, if you don't have a good response rate, makes it harder to interpret the data. There are all kinds of incentives here if you want to get your competitive juices flowing. But when I saw the data last night and saw that Department of Peds, as a very, very large department, had really a great response rate. The next slide, just in case you have trouble finding it in your email, here's the QR codes, but it does close tonight. And so just if you go in your inbox, just hashtag 2024 doctor survey will help you to find the email. It only takes about 10 minutes to complete, and we're so eager to hear your voices. All right, next slide. And then we have monthly MCHRI seminars. I hope everybody knows about these, and welcome everybody to join MCHRI. But we're really delighted that the upcoming seminar on Monday is going to be organizing, recognizing, and rewarding team science contributions. Next slide. And then this is something new we're doing within MCHRI. We have so many resources through the Clinical Research Support Office, the Office for Community Engaged Research, the partnership with the Quantitative Sciences Unit, all kinds of programs in place through MCHRI. We're going to bring all of them together for a community event. We want everyone, all members of your research teams, from your students to your research coordinators to the PIs, to come to this event to fully understand all of the great resources available through MCHRI and the Clinical Research Support Office, things that should be going into grants in the earliest stages of planning. So please join us on that day. And that might be it. All right, with that, Justin Baker, the inaugural and founding chief of our Division of Quality of Life and Palliative Care, will introduce today's speaker. Thank you, Justin.
Thank you so much, Dr. Leonard. It is rare that you get to introduce somebody who has been such an important part of your life, not only in your academic life, but just your life. Dr. Friedrichsdorf has taught my children many things, some of which probably did not help me very much, but certainly were fun to talk about at the dinner table. But just to speak to kind of the global impact that he has had and that we've been able to have together, I just received a picture from Ghana. This happened about 3 minutes ago, and said, "We sure wish you were here with us. Hope you're having a good time with Stefan." And so, you know, the people are paying attention around the world to kind of all the pediatric palliative care efforts that are going on here in the Bay Area. So I'm going to do a few of the official things, then I'm going to make kind of some personal remarks. Dr. Stefan Friedrichsdorf is the Elisa and Mark Stad Professor of Pediatric Pain, Palliative Care, and Integrative Medicine at the University of California, San Francisco. He got his MD in Germany, and he did 5-year residency there as well. He actually did a Pediatric Pain Medicine and Palliative Care Fellowship at the University of Sydney. And he is one of the very, very few people in the United States that is joint certified in pain and palliative care. You might have recently heard about the work that he's doing with the Comfort Promise, and he's going to be speaking to us about that, the Benioff Children's Hospital's Comfort Promise. We promise to do everything possible to prevent and treat pain for every child, every time. That recently aired as an NPR story and really got a lot of play also at Endwell this past year. We do a lot of work with something called EPIC Pediatrics, which is Education in Palliative and End-of-Life Care, the pediatrics iteration of that. Lexi, Stefan, and I are core leaders on the event that's happening this week. We actually go up there tomorrow and start our conference, and so it's really nice to have Stefan here. He has given more than 800 lectures globally, and he's been very highly academically productive with 60 peer-reviewed articles, and he's contributed 25 books. He is the immediate past president of the Special Interest Group on Pain in Childhood and at the IASP. And when I, again, think of kind of the times that we have spent together, we have been from as interesting of places as Nazareth in Israel. In fact, I'm doing grand rounds on Thursday at UCSF, and the picture I'm sharing is one right on top of Temple on the Temple of the Rock, and right in front of Al-Aqsa, right there in Jerusalem. And we have been to such mundane places as Memphis, Tennessee, and Minneapolis, Minnesota. And I think when I think about Stefan, I think about how innovative he's been and how he's brought together these three entities so beautifully: pain, palliative care, and integrative medicine, and how wonderfully he has navigated the academic world. He and his wife, Ruth is also a pediatrician, and they've raised 3 amazing children. And it's so cool to see him do that and succeed so beautifully in Minnesota, and now here for the past about 5 years in the Bay Area. We have big plans for the Bay Area, thinking about partnerships with UCSF and Stanford. And so as we were thinking about our early grand round schedule, there was nobody better that we could invite than Dr. Stefan Friedrichsdorf, my friend. And we are presenting him with a koala and with our favorite book, The Rabbit Listened. So here you are, my friend.
Thank you so much. Good morning, lovely people. Good morning. Are you ready? Yes. We had 3 coffees. Justin, thank you so much for those kind words, and thank you for having me here in this morning, because clearly the main thing I'm here is to demonstrate that of course we're competitors, right, in the market, and we all this language. At the end of the day, we're not going to compete about taking care of dying children. We're not going to compete of children with suffering. We need to do the bloody best we can do in the Bay Area of taking care of the children here. And whether this is at Stanford, whether this is at UCSF, and it needs to be in the children's hospital, right? We have to get those kids out of the adult hospitals to us. That's what this is all about. All right. So I have nothing to disclose. All my slides, if you have any trouble falling asleep tonight, are in this, all my handouts are in there. And I will also send them to Lexi and Justin, so you can just contact the team if you're interested in every single slide for that matter. All right, palliative care. You are taking care of a child who is seriously ill tonight. And you would not be surprised if she might die within the next few days or weeks or months. You don't know, I mean, the next pneumonia may or may not, you have no idea. So you're considering to put in a palliative care consult. What might you hear from your colleagues? What might you hear from parents that this is not a good idea? We're not giving up, thank you. Yeah, who said that? Yeah. This clearly is giving up. I mean, the second, right, we are having a palliative care, that means we're giving up hope. The second I'm opening the door, hope is just sucked out like oxygen, right? And like the family is like devastated. So we are clearly cannot. What else might we hear from colleagues or from parents? The family's not ready. Yeah, totally not ready. I mean, they're clearly not ready for what we have to offer, which I'm going to talk about in the next hour. And then it's the question, the family is not ready, or the who? What else might we hear? They don't want to be a team. I mean, it's clearly, I mean, this is just too much, right? I mean, they have, of course, well, we need antibiotics, so there's infectious disease in, right? And there's GI problems, so gastroenterology is there. This with the skin, we have dermatology all there, right? There's the hip issues. I mean, orthopedic surgery is there. And then, of course, we have sort of ICU, the neurologist is there. Actually, they have two neurologists, right? So, and they're clearly adding another team to that mix is basic, is devastating, but that clearly is not something we should do. Love it, thank you, sir. What else? This is the palliative silence. You know, this is where I'm quiet and you just listen to wait what the family is saying. So there's a lot of stuff going on. So I'm going to talk about very quickly what is pediatric palliative care in 2024. And then let's talk about hope. What is this thing we are conceptualizing as hope in the face of an uncertain prognosis? And then we have Jen here, good morning, our fearless leader of pediatric pain. So we're also going to talk about how advanced pain and symptom management is absolutely fundamental in pediatric palliative care. First, you have to take the pain away, and then the family is ready to talk about psychosocial spiritual concepts and other distressing symptoms. And then I'm going to give you some recommendations, what I found helpful in the goals of care discussion. Yes, what is this magic thing when we go in and then we come out? And the team basically says, like, how did you do that? So I'll share those tricks with you. And then we go. Palliative care, palliare to cloak, is sort of an extra layer of care. All it is we want to match the treatment to the patient's goals. Are we doing the right treatment for the goals of the child and the family? Or is it too much or too little? And so specialized medical care for children with serious illness, we're focusing obviously on relieving pain, distressing symptoms, and stress of a serious illness. It's appropriate at any age. It is appropriate at any stage, together with curative treatment. And clearly the goal is to improve the quality of life for the child and the family. And this is the kicker, it is always interdisciplinary. There's no freaking way. You cannot do it as a single person. We have learned this the hard way. We must have, there's no other way, have an interdisciplinary team, interprofessional team of physicians, nurse practitioners, social work, psychology, child life specialists, nurses who are providing this kind of care. Because we're all trained in a different way, and all together can we do this well. I met Matty Stepanek in the early 2000s, and he has seen several of his brothers dying. And when he was asked, what is palliative care? He said, you know, palliative care no longer means helping children die well. It means helping children and their families to live well. And when the time is certain, to help them die gently. All right, so what research do we have? What data do we have on the like if a team with a serious illness, if palliative care is involved? If I could ask you both on Zoom, hello lovely people, and here in person, to use this QR code, or if you have issues with QR codes, you can go to strawpoll.live and use the code 440572, strawpoll.live, and use the code 440572. So which of the answers are correct? And there might be more than one. Like parents with seriously ill children report that if we include palliative care, this results in what? And I give you 27 seconds. All right, take as many moments as you like, even up to 5 seconds. No pressure. All right, so we have leading less distress with 38, all the way down decreasing for families hope for cure, 11 votes. So let's look what the data shows. What are the outcomes in pediatric medicine if a palliative care team is involved as an extra layer of care? Well, parents actually of children with cancer report less distress from pain, dyspnea, breathlessness, and anxiety in the end-of-life period. We published an article where we actually looked at those children with cancer who were enrolled also in home palliative care program, were more likely to have fun and were more likely to experience events that added meaning to their life. Parents report then, if palliative care is involved, that they have significantly improved communication to their other teams. Children receiving palliative care consults have shorter hospitalizations. There are fewer emergency department visits. And receiving specialized pediatric palliative care was associated with a better quality of life of the child. Kids have fewer diagnostic and monitoring procedures and improved pain management documentation when palliative care was involved. So I lived in Minneapolis for 15 years, to quote Charles Schulz, someday we will all die, Snoopy. True. But on the other days, we will not. So let's talk about this hope thing, because that's the number one thing we hear where clearly palliative care is useless, right? We shouldn't have them because the second we get them, we're giving up their sort of hope. So let's talk about this a little bit more. So because we have this assumption that parents have to choose either really hard to not have any stone unturned and fight for the child, or, well, there's nothing else we can do. We have to give up, and we call the palliative care team. The body language alone is like, well, we could sort of do this first one trial, or we give up and call the palliative care team. If we sort of sell this to our families like this, of course they think this is a sort of a very terrible team. And there's still the assumption among many families and some of our colleagues that palliative care translates into giving up hope and doing nothing. So let's look a little bit more into this hope at phase of serious illness. So going back into Greek mythology, Pandora's box, the box actually was a jar, and was given to Pandora, which contained all the evils in the world. You know how the story ended? She did open it, and all the evils flew out, explaining a lot what's happening in our country and other places now, probably as we see. Anyhow, point is, hope remained in the box, in the jar, once she had closed it again. So taking care of a child who is seriously ill, that's really, really, really difficult. It's difficult for the parents, for the friends, for anyone clinically is involved. And especially if we don't know where the outcomes is, and we have sort of a long longitudinal relation with this family, this is really, really difficult. And we of course know that parental loss is probably considered to be the most difficult type of loss. So the emotional cost of recognizing that the child may die impedes often the planning for optimal care and support. So Fluffy, just another content expert here, is there any evidence that including the palliative care team effectively results in giving up hope for the family? All right, so you can either trust Fluffy or we look at the research. So what about hope? So this is adult data showing that if we engaged adult people at the end of life into advanced care planning, this increased the knowledge without diminishing hope, without increasing the hopelessness, nor inducing anxiety in adult patients with advanced cancer. And what we see in pediatrics as well is disclosure of a terminal prognosis does not mean loss of patient hope. Instead, the hope is redirected at something else. Maybe not at the cure, but something, well, maybe I want to go to Hawaii one more time, right? Maybe I want to see my grandchild. That's the hope is redefined. So what about pediatric data? There's actually, to the best of our knowledge, no evidence that the prognosis disclosure makes parents less hopeful. In fact, if we disclose the prognosis, best case scenario, worst case scenario, most likely scenario, this is going to happen. But a physician can support hope even when the prognosis is poor. Of course the parents are upset. I have 3 kids, 3 teenagers, all in high school right now, lots of drama going on, right? If I come to Stanford right now and you tell me there's something bad going on, of course I'm going to flip out. Any one of us would. Yet, the prognostic information does not mean that I do not want it, or parents do not want it. The upsetting nature of this information does not diminish the desire of the parents to make this information. So we basically have a new hope. We have to redefine what hope is. Actually, the parents are doing this. We don't have to do this for them. The children have to do it. And of course, we have many parents who continue to opt for continuing treatment, even when there's no realistic hope of cure. Maybe the hope for a miracle. Maybe the hope, the desire to extend life, the desire to be a good parent, and a good parent feeling like we just have to find something else. Or they hope that maybe this palliative chemotherapies will palliate symptoms related to a progressive disease. And we will talk about a little bit more about miracle and how we can respond to this in the last part of the section. But what we can say to families is that in order to achieve the miracle, you do not have to continue on disease-directed therapy in order to preserve hope, especially if what we're doing reduces the quality of life of the child. But these are difficult decisions, and these are decisions often between the primary team, whom the family trusts, and the kids, and need to be done on a case-by-case basis. We do know, and this is Justin published, and that data is that often people say when a do not resuscitate order means you're not caring for my child anymore. And data showing that's actually not true. Even if children on the intensive care unit have a do not resuscitate, allow natural death, do not intubate order in, that in fact the level of care, the level of medical care remains the same. Even when we cannot cure the underlying condition, we have sophisticated medical technology which we will use to do the bloody best we can do to have the best pain and symptom management and to have the best quality of life. So again, pediatric palliative care is a very active and advanced approach to pain and symptom management and support for the family and the child. All right, part 3 out of 4, addressing pain and reducing symptoms. So I've been in the United States for 19 years now. As you heard from Justin, we go worldwide, and we talk to many of our colleagues. And so Dr. Cox, simple question. In the United States, the majority of children with serious illness have excellent pain and symptom management, correct?
For me to good God in heaven, maybe there are just so very many ways for me to say this to you. Never, not in a million years, absolutely not. No way, Jose, no chance, Lance, yet, negatory, nah, and of course my own personal favorite of all time, man falling off of a cliff. No! Oh, Dr. Cox.
In most places where children are seen by clinicians, pain is everyone's problem and nobody's responsibility. You do have, Jen, you have a pain team, so this is pretty rare. In most children's hospitals in the United States, pain management is an absolute freaking disaster. And those of you who've worked for more than 10 minutes in the medical field know what I'm talking about. And even at our own places, I assume here in Stanford, certainly where I'm at UCSF for the last 3 years, it really has been quite a journey to change that. Now, going back to palliative care, we basically have the expectation that when we get old, so when I'm at the high age 125, right, and I suddenly like enter my last end of life, that a lovely hospice nurse will come to my house and I will get some morphine and I will, like, with my dog or cat on my lap, will die. That's not happening for kids. The vast majority of children right now do not have access to an interdisciplinary palliative care team. Less than 5% of children with serious illness in the United States actually see anyone who's even vaguely trained in advanced pain management, in advanced symptom management of nausea, vomiting, breathlessness, seizure management, for that matter, or sort of any palliative care training. And of course, that this is from Joanne Wolf's group, showing that if you ask children with advanced cancer about distressing symptoms, they have a huge number of distressing symptoms, somewhere between on the scale of about 9 at the same time, 9. And the more that come into end of life, the more they are. And of course, they significantly decrease the quality of life. And you see pain, fatigue, nausea, constipation, anorexia, itching. That's a big thing. And we know that lack of energy, again, this is another study we just published, is really, really common in children with serious illness. And the point is that clearly the symptom distress is strongly associated with the quality of life. It's sort of like duh. So if a child is in pain, quality of life is much worse. If it's in pain and nauseous, the quality of life is much worse. It's in pain, nauseous, and fatigue, and we can do better. This is not rocket science. We can do advanced pain and symptom management, yet it's not happening for most children in the United States because the system's not there, it's not my job. We don't actually know how to do this. And this is why we have created Epic Pediatrics to teach how to teach this stuff. What is the evidence-based in end of life for breathlessness, for nausea and vomiting? What can we do to have a much better symptom control? Because even when you inform the teams, this is in children with advanced serious illness, including cancer, the majority of the distressing symptoms, such as unrelieved pain, dyspnea, and nausea and fatigue, were not treated. This is sort of a main academic teaching hospitals here in the United States. And when they were treated, the therapy was commonly ineffective. Oh, that kid is nauseous. Well, let's put some ondansetron on, or like put some other sort of antiemetics in there. Not understanding that just a choice of different antiemetics is not enough to treat nausea and vomiting in a child with serious illness. So this is a patient I had the pleasure to work with, a family to work with quite a few years ago at Children's Minnesota. So Ethan actually had a bad heart defect. It was a left hypoplastic heterotaxy and MAPGA. So he was really not doing very well. And this is sort of back in the days of that after his first palliative surgery, he was on ECMO and on extracorporeal membrane oxygenation. And he unfortunately had an underlying clotting disorder and received significant strokes. So he was very uncomfortable, and 2 different neurologists basically told the family that they would not think that Ethan would ever be able to see, able to talk, to walk, to sort of eat and drink. And he seemed to be sort of somewhat uncomfortable. So we got the consult to start an end-of-life conversation, or basically start a goals of care conversation, to correct myself, and also to sort of provide better pain and symptom management. And so when I get a pain consult, right, I'm a pain specialist and a palliative care specialist, and a kid is flipping out with a nonverbal child and somebody measures 8 out of 10 pain, what are we dealing with? Acute pain, chronic pain, neuropathic pain, visceral pain, total pain? Is this withdrawal? Is this delirium? So what is this 8 out of 10? So, and of course, we check our boxes, right? If Jen goes in, she's like, okay, are there possible sources of pain? Is this GI? Very big in many of our kids with serious illness, visceral hyperalgesia, neurogenic bowel, spasticity, musculoskeletal, orthopedic, right? Are we missing a fracture? Osteopenia, is this a UTI, a neurogenic bladder? yeah, a torsion, stones, menstrual cycle, ophthalmic, like with quite a few kids who may have a corneal abrasion. So we need to sort of look into the eyes. Yeah, is that cavities, an abscess, dental? Have we looked into that? Skin, right, with burns, ulcerations, hair strangulation, and for that matter. Ear, sinus, throat infection. Have we looked into the eyes, into the ears? Yeah, is this an infection? Is this an autoimmune disease? Yeah, is this a seizure? Yeah, chronic headaches, abdominal headaches, migraines. I mean, what is that? Like, yeah, is this neuropathic pain, visceral pain, anxiety, depression, delirium, withdrawal? All of this can sort of be part of this. Is this total pain? Total pain is real pain. That is 8 out of 10. Yet we cannot treat this with morphine or methadone. Is this us? So basically, I alluded to that the common mistake is we have a medical problem. This is the range of medications we're giving. That fails 50% of the time. What we teach at Epic Pediatrics, what we teach in advanced pain and symptom management, it's always 4 steps, sometimes 5. Step 1 is, of course, is like you evaluate and assess the patient. And then we see, is that sort of the problem? And then step 2, we basically treat the underlying causes if we can. Step 3, using integrative non-pharmacologic modalities, psychology, physical therapy, hypnosis, aromatherapy, all these modalities. And then step 4 would be medication, and step 5 might be then an intervention. So again, if we have a child with distressing symptoms, we think pain is the problem, it could be a tissue injury. And maybe we're able to treat this. Constipation, a big thing, right? And very huge when we're dealing with children with serious illness. Is this neuropathic pain, which we would treat very differently than acute pain with a tissue injury? Could this be a spasticity or contracture? Yeah, we're sort of dealing with. Yeah, reflux. Yeah, might this be insomnia? So the kids are up all night and they're sort of sleeping through a day, and we try to fix that. Is this nausea? Yeah, could it be delirium? Are we using the CAPTI score, the Cornell assessment of pediatric delirium? Right, anything higher than 9 is sort of worrisome for every child, especially when they're nonverbal, especially on the neonatal intensive care units and pediatric intensive care units. Could this be a seizure? Or is this huge area of children we're seeing every day with feeding intolerance, visceral hyperalgesia, the kids with the feeding tube? We're sort of in trouble. So when we consider how to address pain and distressing symptoms, I'm giving pain here as an example in a child with serious illness. Of course, number 1, we evaluate, we do perform a clinical exam. Number 2, we treat the underlying causes. And number 3, we use integrative therapies. So I'm lucky to, at UCSF, to have one of the, if not the largest integrative medicine program within a children's hospital in the United States. So we have massage therapy, we have acupuncturists, we use aromatherapy. I'm trained in hypnosis, so I go into the room and may give fentanyl or hypnosis, or both, sort of at the same time. And this is sort of highly liked, right? So this is like an integral part of state-of-the-art medicine in 2024, is to have a solid integrative medicine program. And sometimes we can just use it as part of a toolbox, sometimes for people who are specifically doing this. Mind-body techniques, breathing, progressive muscle relaxation, hypnosis, aromatherapy, yeah, that sort of is very easy. 5, yeah, and when I say breathing, 5-finger breathing, it's like, that takes like 5 seconds. Up behind, take a nice breath in and out. That's great. Do another one. In and out. 3 more. So that is 5-finger breathing. And the last one, the biggest one ever, that took me 7 seconds while I'm rounding with a patient. Yeah, so I don't need like a breathing specialist hired tomorrow to doing this. Like, we can do that. Yeah, every one of us can use 1 or 2. The aromatherapy you can have in a pocket, right? Okay, we have peppermint and lavender. Which one do you sort of prefer? So many of the integrative things, they're just there. And together with nursing, with child life, with nurse practitioners, with clinicians, yeah, you can basically already offer half of the stuff tomorrow. Yoga, massage, we call this acutherapy. So this is huge and very popular, acupuncture and acupressure in our service. And then I already alluded to, like, we must have an interdisciplinary team. It cannot be done otherwise. So we need social work, yeah, who provides family support, psychoeducation, supportive counseling, parenting guidance. Yeah, do they need respite for that matter? Rehabilitation. The importance of physical therapy and occupational therapy cannot be understated, and how important they are to provide really good management. We know post-operative, if they get out of bed on post-operative day 1 or 2 instead of exercising, we get them home faster, they heal faster, they need less opioids. PT is awesome. Yeah, so we need much more of this. Psychology. Yeah, so assessing anxiety, mental health, depression by therapists, yeah, and then who can use CBT clearly need to be part of this. Spirituality, child life specialists who are just like the best thing ever, like walking in water, right? So we need enough child life specialists for sort of in our team. And when you talk to your physical therapist, there are different levels, right? There's sort of the low-level physical therapy, which is, oh, you've injured your right elbow. Well, how about you do those right exercises and move your right elbow 50 times? That's boring, it hurts, the kids are not going to do this. Yeah, so this is sort of very 1984 physical therapy. What now advanced physical therapists do is really, they think much more about, okay, what does this kid want to do? How do I get you back to rowing, right? Or basically just going back to school. And we're really using much more like graded motor imagery, right? So using like a mirror therapy, for instance. So this is a child with complex regional pain syndrome, CRPS, and her left hand hurts quite a bit. So she basically puts it in the mirror box, and she's exercising the right hand, but the brain thinks it's the left hand. So you can actually reorganize cortically, yeah, the exercise you can do physical therapy without the pain. This is a 7-year-old boy who underwent, after an osteosarcoma, an amputation. So if you do poor pain control, they're very likely, before the amputation, they're very likely to develop phantom limb pain. So again, that's really, really difficult to treat. And other than either with virtual reality or this $19.99 mirror, this kid actually has exercised the opposite arm, the brain thinking it's exercising the phantom limb, and he was able to get rid of his phantom limb pain. So that's just an example of, yeah, we can use every single medication on the planet. If we don't spend the $19.99 for the mirror, yeah, it's not gonna work. And then of course we do think medications is awesome, right? This is, yeah, we think about basic analgesia, acetaminophen, Tylenol. We think about NSAIDs. We think about celecoxib as sort of a plan B. If we are worried about bleeding, a COX-2 inhibitor is pretty safe for that matter. We think about opioids. Yeah, opioids still in 2012 play a major role in treating and addressing pain, in making sure that children have management in sickle cell disease, in post-surgery, in after burns, after trauma. Yeah, we can't sort of take this away, even if there's a potential side effect. And when we think about opioids, they all work equally well, but of course, methadone is the queen of opioids. It's a much, much better drug because you actually have 3 drugs in one, right? You have an opioid like morphine, you have an NMDA, an N-methyl D-aspartate channel blocker, such as ketamine, and you have a serotonin, noradrenaline reuptake inhibitor like amitriptyline. So you give a whiff of a splash of amitriptyline, a whiff of a splash of low ketamine, and hydromorphone-dilaudid morphine in there. You need much lower doses. It's really something which has revolutionized, I think, pain specialists and in palliative care, because we're using it at much lower doses, much earlier sort of in the game. And a common mistake I see kids who are industrial doses of hydromorphone or industrial dose of morphine, not recognizing that that actually is metabolized into bad guy. Yeah, so morphine is metabolized into morphine-3-gluconide. Dilaudid hydromorphone is metabolized into hydromorphone-3-gluconide. And if you give doses more than 10 times the standard dose, that bad guy is causing excitation, delirium, and really nociception, more pain. And switching it over to a medication like methadone, IV or orally, could be like is a game changer for many of our children. Gabapentin, yeah, so vitamin G. That's probably the most common used adjuvant we're using. Yeah, tricyclic antidepressants has come a little bit out of favor. It is very, very effective, but because of the high toxicity at home, we are more and more careful prescribing that for that matter. And I told you that the #1 problem in children with feeding tubes is they will always 100% develop feeding intolerance and visceral hyperalgesia. There's no 99-year-old lady who's walking around who got a feeding tube 99 years ago. It's just a question, is it going to happen in 1 year, in 5 years, in 15 years? It will happen. And then at this stage, if we have the feeding is causing the pain, especially if the kids are sick, yeah, if you are in the middle of COVID, like you don't want a feeding tube and basically have some 24-hour feeding in there, right? You already feel sick. So when we're sick, we don't have that much of an appetite. Then we can think about gabapentin or pregabalin, Coke or Pepsi. So that is something which often buys us a year or 5 years for this matter. Yeah? Actually, a 5-HT3 receptor antagonist, such as ondansetron, is actually really effective, not as an antiemetic, but for visceral hyperalgesia, for that matter. A whiff of a splash of a tricyclic, really low dose, not at high doses, might be very helpful. Of course, a prokinetic, some metoclopramide, Reglan, some low-dose erythromycin is something we might consider. Cyproheptadine, with no clue how it works, yeah, but it's like, yeah, because it's a serotonin agonist, but really often helps, especially with the stretching and sort of the dry heaving of the children. So that's something we might use. We change the formula. We go from bolus to continuous, from continuous to bolus. I mean, that's sort of lots of magic. And there will be a time when there is no other way to reduce the artificial feeding and hydration. It's going to happen. The question is when? In a year? In 5 years? Right? So this will basically, kids need less. And they don't, especially if they're in a wheelchair, especially if they're not walking around, they don't need the amount of calories a 5-year-old needs who's supposed to go to college. They need half of the amount of liquid and calories. However, often, not always dietitians take this into account, and they sort of use the amount of fluid, and this is always a big discussion fight we're having. Alpha agonist, awesome. Those of you who work on the neonatal intensive care units, of course, you know dexmedetomidine and Precedex is an amazingly good analgesic and sedative. Cheap clonidine also so not as great, but also works as well. We can use this enterally and or as a patch. Low-dose ketamine, we use this as water. So as a pain director, we probably have at least 10 children every day in Oakland and San Francisco on low-dose ketamine. Significantly opioid sparing, really provides much better analgesia as part of modalities. Lidocaine infusions are awesome, but they're really not user-friendly. Yeah, so we have to draw the blood every 8 hours, and it's sort of much more toxic. So this is more number 17 on our list. But we have some kids. I recently have taken care of a child with erythromelalgia, so sodium channel blocker, a lithium sodium channel blocker, where that, yeah, and then switching over to mexilatine, another sodium channel blocker, was very effective. And then, of course, this is why you can be proud of this. Here at Stanford, you have experts from pediatric anesthesia who can help you to think about new axle infusions. A tunnel catheter, an epidural, a tap block. Yeah, so this regional anesthesia is very, very effective, and it's often not done or too late. So make sure that when you round together, you basically make sure, is this something we should consider in this particular child? More information in your handouts about what modalities sort of have been published, and sort of we will go through this. And then we have other adjuvants, right? The hydroxyzine is my favorite antihistamine, antimuscarinic. We try not to use Benadryl, diphenhydramine, especially not intravenously. And that's really a side to sort of kid flipping out at 3 o'clock in the morning. We need something to calm them down. So then that's the how get out of my emergency room medication, right? Hydroxyzine is something to consider. Botox, low-dose propofol at a very low dose, 0.5 milligrams per kilogram an hour. Kids are still walking around, really helpful for intractable nausea, for intractable pain in end-of-life scenarios. Capsaicin, yeah, and think about an SNRI. And then sometimes, despite all of this, nothing is working. And this is the rare case where we might think about palliative sedation. That is something which is necessary once every 3 years. Yeah, so if you have palliative sedation every 3 days, then clearly there's nothing like there's something wrong with your sort of advanced pain and symptom management beforehand. Yeah, so but that's something we would consider. So if I stay for another day and I will talk to every single child who's going to see you now today, which you're seeing, and ask you, what are you most afraid of? Seeing that doctor, this MA, this nurse, this social worker, right? What are they going to tell me? It's the needle pokes, right? So we published that in the Journal of Things we already knew. Kids are really, really afraid of needles. That's the number one thing they really care about. Because when they come to us, this is what they get. A healthy child will have 16 to 20 vaccinations the first 2 years of life. Once they're sick, oh, we add much more. Electro here, an IV cannulation there, an injection there. This is sort of what kids are most afraid of. So a few years ago, I was teaching at the Scandinavian Pediatric Pain Society, and they showed that video. So it's in Danish. Anyone not fluent in Danish here? Anyone? Yeah, so even if you're not one, okay. So even if you're not in Danish, this is a 1-minute video. This is a 5-year-old boy by the name of Marius who will need some stitches. And things are starting really well. This is Denmark, right? Fantastic nurse, there's stickers, he's really cooperative. And then something is going wrong. And I wonder whether you can tell me what's going wrong here, even if you're not fluent in Danish.
Op her. Han har fået revet det yderste stykke af fingeren af, og det hænger meget løst. Hvad var der sket? Nu pakker jeg den op forsigtigt her. Så kommer Mikael.
Du kommer til skade med fingeren.
Jeg pakker fingeren ud af forbindingen. Kan jeg se, at det er det vi gør, når vi skal bedøve fingeren, sådan så at det ikke kommer til at gøre ondt, når vi skal rense og sy. Og berolige drengen hele. Altså, vi holder hånden der. Sådan en 5-årig dreng kan godt være rigtig stærk, så vi er nødt til at hente noget forstærkning, som simpelthen kan holde ham fast. Både at bedøve fingeren, og vi er ikke nogle flere kollegaer, og så er vi 5 voksne mennesker, der er nødt til at holde hans lille arm, for at vi kan få det.
Should we quickly count how many adults are holding down this 5-year-old child for an elective procedure? We're not saving lives here. And when I present this kind of data, it's like, you know, Stefan, I hear you, but we just do not have enough staff for pediatric pain control. It's amazing. We always tend to have staff to hold down children. This is unethical. This is bad medicine. In 2015, a year later, my biggest presentation to date. I was at the American Burn Society. There were 3,000 people in the room, every single trauma center in North America, most in the world. And I showed that video. I said, how many of you are certain that this could not happen tonight in your hospital? How many hands went up? Not a single one. Things have changed in about 50 children's hospitals in the world. And a common thing when I started doing this, I asked our staff, so how well are we doing? We just asked our staff at Children's Minnesota, like, how good are we in treating and preventing pain? And when we asked our staff, the results were very encouraging. Our staff gave ourselves a 9 out of 10 in awesomeness in preventing and treating pain. That level of enthusiasm, however, was not shared by patients at all. They actually told us, hands down, that pain is the number one thing, and that we were much better in like post-operative pain, cancer pain, so that was working. Needle pokes, hands down, is the number one thing kids worry about. And we do a terrible job because it's nobody's it's everyone's problem, and it's nobody's responsibility. Well, I'm just here. I mean, I have to do this right now, just like hold him down, put the needle in, it builds character, doesn't it? It does not. It causes huge problems afterwards. So basically, the comfort promise, or a version of this, nothing of this is proprietary, basically means we are now implemented this at Children's Minnesota for every child, every time. And one of the reasons I came to UCSF, we're now rolling this out unit by unit for every child, every time, is to basically make sure to have child life specialists available, is to offer numbing cream. Every child will be offered numbing cream, lidocaine 4%, term infant and above, not premature infants. Every time. Every child, everywhere. A teenager may say, just go ahead, I don't care. That's fine. No 2-year-old is going to opt out. No, please hold me down. I don't want the numbing cream. Yeah. Comfort positioning. It is bad medicine. It is terrible. We were all trained the best ways to pin them down and do them fast. We now know this is crap. This is bad medicine. This is unethical. And this has to stop. We do not have ever to hold down children, unless we're saving lives. Yeah, that's a different thing. But 99% of the time, when we put a needle into a child, this is not a saving life situation. That's just like, we need to get our work done. Age-appropriate distraction. Yeah, so anything from bubble blowing to apps for babies, little spin wheels. Allow some patient control, help them to sort of like, they can say stop, they can sort of ask for a break. And then for babies younger than 12 months, we offer sucrose or breastfeeding, one or the other. And for older children, we praise them afterwards. We change sort of a memory. Much more information. I have a 1-hour talk on that, on that QR code. And then we do not recommend intranasal midazolam, pH of 2. It's not an analgesia, so that's really, again, we may use intranasal dexmedetomidine if we have to, but nitrous gas, of course, hands down, is the #1 thing to offer for those kids where this is not going to work. Kids with severe autism, kids of anxiety, kids who have been held down many times. So you will need nitrous gas. And we've implemented the largest nitrous gas program in Minnesota, and we now at UCSF just bought the nitrous gas machines, and we'll have a nurse-led nitrous gas program at Benioff. All right, in the last few minutes, part 4 is moving from pain and symptom management back to the hope thing, the goals of care discussion. Yeah, so if you give me a consult and said, okay, like, can your team, your interdisciplinary team, please meet with this family? Then I would go back to you and say, like, how can I help you? Yeah, I'm attending this week, like, how can we help you? So, and then do we get this right? Do you want me to prescribe the methadone, or are you going to do this? Right? Do you want me to talk about this? Like, so we basically, it's a dance. It's not like, okay, step aside. Yeah, the palliative care saviors come. This is not, it's an extra layer of care. Yeah, I'm a consultant. Like, how can I help you as the primary team? And let's discuss this, right? Let's sort of, it's like this, yeah, do you want to come with me when I'm talking, yeah, or not? Does the resident want to? And then, of course, we introduce ourselves to the family. And then usually, sort of, the thing we teach is to residents, to fellows, and I often do this, is basically sort of go in and then, like, we start with an icebreaker. Yeah, so I introduce myself, yeah, I give my name. I describe palliative care according to what the primary team has told me, yeah, which sort of makes most sense in this current scenario, which they may have heard. And then it's like, yeah, so tell me about your child. Tell me about Ethan on a good day. And then you hear and they listen to this, right? And that is a nice thing. And then I also internally think, okay, I will ask, like, how many good days and how many bad days in the last 6 months? Yeah, so you sort of get an idea. Parents love to talk about the children on a good day. This is why we always have those pictures outside, right? They want to remind us this is sort of what our normal life looks like. Intubated, nonverbal at the moment, sedated is not what the normal life is. Part 2 is really to explore the family's understanding of the child illness. So you probably had, yeah, I looked at the chart. You actually spoken to 537 different doctors, yeah, during this hospitalization. So I wonder, what did you hear? What's your understanding of what's going on? Yeah, how did we get here? What have you heard from your primary team? What might be the best case scenario? What's the worst case scenario? And again, the range you're sort of hearing is something which may not work. And then the single most important question, the highlight of this presentation, the #1 thing, if you only take one thing home, the one thing is asking for the goals of care. What are your goals of care? That doesn't work. Yeah, it's something like, so considering what Ethan is up against, what are you hoping for? Considering what Ethan is up against, what are you hoping for? I hope for cure, I hope for miracle, I hope to put the odds. I hope this too. I hope this too. I'm a father of 3 children. I hope this too. I have no idea what you're going through. Just in case this miracle is not going to happen. Yeah, so what else are you hoping for? Many families, not all, are willing to go there. Well, if the cure will not happen, hypothetically, then this would be imperative. Pain management, symptom management, getting grandmother here, going home. So this kind of things. And then you can sort of talk about that. What are your worries? What keeps you up at night? And then we reframe it. So what I hear is saying there's a lot of clinical uncertainty, right? The best case scenario is that the next treatment will keep this at bay and you may have many more decades with your child at home. Do I get this right? And the worst case scenario is we don't know what happened. It's possible that your child may live for a very short time. Do I get this right? Okay, so let's plan for the best. Yeah, and let's hope for the best and also plan for the rest. We ask about, where do you find your strength, about support, spirituality, self-care, how the siblings doing, how do you manage day by day for that matter. And then wrapping up is really sort of getting an idea about the siblings. These are usually the kids who suffer most in that family scenario. What are we doing for them? Yeah, so what support are we providing to the healthy sibling? Because if they don't get support, they have a much higher risk of mental health issues. And we can talk about, some loving families in the situation decided the best way to love their child is to put in a trach. And if this was what you want to do, we supported this. Equally loving families in the situation have decided that they do not want to put in a tracheostomy in their child. And that's okay as well. You just need to know that loving families make different choices. So if somebody comes in, your child needs a trach, or your child needs a GI tube, that's actually his fault. Yeah, your child doesn't need that. It's a choice. And it might be the appropriate choice. But the parents need to know that a choice is a choice is a choice. So I may then recommend the following. And then I take back to the parents and may or may not give the recommendations. Half the time, there's a stage where we may or may not address a DNR. Sometimes it don't. And so it depends on how this is working. So it very much depends, right? And if I want to address code status, I may basically say like, so if these are your goals, may I make a suggestion? Yeah. Just in case, I don't think that's going to happen, but just in case your daughter's heart or Ethan's heart is going to stop beating tonight, or stops breathing, then, loving families may realize that the child has come to a natural end of life. Or I may say something like, we would use all intensive comfort medication, oxygen, suctioning, comfort positioning, sublingual morphine, like whatever there is, yeah. And I would recommend to avoid all painful procedures, such as chest compressions, which may break ribs, or like intubation. Would that be fine with you? And the family says yes or no, or they're going to think about this. So I might recommend to put in order to protect your son, Ethan, from experiencing painful situations. So finishing up, many sort of the cheat sheet words we use is like, I wish that too. I wish that too, but at this stage, this is not possible. Yeah, if there's a lot of emotion, I can't imagine what this is like for you. And then I'm very aware of the time. It's 2 minutes to 9, so I'm very aware of the time. So in the last 2 minutes, so we share this with the family, because sometimes otherwise it may take 5 hours to do the consult. It's like, I'm very aware of the time. Like, we have another minute. Is there anything else you'd like to talk about in that minute? Yeah, because we want to make sure that your child lives as long as possible, as well as possible. So, and then usually we end up, when we do this discussion, there are only 3 outcomes. The first outcome is the family in the green bucket says they want the child to live as long as possible. They accept suffering as the price to pay to live longer. They don't want suffering, but they would accept it. And that's a choice. And many of our families do this. That's not necessarily a choice where we as palliative care would be sort of majorly in the front, but we sort of check in. And when they're ready to join the second one, to live as long as possible, as well as possible, this is sort of like, yeah, probably, I may intubate for, if he has a pneumonia and this can be treated for 2 days, but I would not want a tracheostomy. Yeah, I will decrease the feeding. I'm not going to go home on home TPN, right? So if parents sort of, okay, there's certain things we're not going to do, but you sort of negotiate that, maintains or improves the quality of life, they may do this. And then they come into the yellow sort of hospice bucket. So what can we do to live well as possible today? So finishing up with Ethan, the family decided for compassionate extubation. He was not breathing above the ventilator. He was already on midazolam and on fentanyl as a sedative. And so I talked to the family, and and the team expected that he may die very quickly. And so he was there, his 8-year-old sister, parents were already there. And the family said, we don't want him to be on this tube. We want a compassionate extubation, but you have to promise me that he's not suffering. I said, okay, I'll be in the room. Yeah, and discuss with the cardiologist. Sometimes they do this themselves, sometimes it's me. So I mean, it's like for each patient's different. In this situation, I was there and basically had a fentanyl and a midazolam PCA, which I was controlling. He had this continuous infusion. He was then extubated, and basically, like in 50% of the cases, Ethan decided not to die. Because half the time, babies just they somehow don't die. They just sort of keep breathing. He was very dyspneic. As you know, opioid is the #1 thing to treat dyspnea, breathlessness, right? So I need to give him quite a bit of fentanyl PCA boluses to overcome this breathlessness. And I actually had to increase over the next 3 hours the continuous infusion of fentanyl and midazolam by ×3. So he got 3 times as much fentanyl and midazolam after the extubation than before. I didn't kill him, right? This was just sort of treatment, because we're often afraid of doing that. And then after a few hours, I said, like, let's go outside. He had never been outside. So we went outside, we went sort of into the sun, and that's sort of, you know, somewhere behind, like you have the smart pumps for midazolam and sort of fentanyl. And then the next day, basically, the family said, it's like, okay, we want to go home. And of course, every state-of-the-art program, you must have a system in place that you can send these kids home. Like, who is taking care of this, right? The family needs, at 3 o'clock in the morning, need to be able to call someone if there's a dislodged G-tube. He didn't have one, it just didn't need to. And so he went home, we enrolled in our home palliative care program, and exactly 4 weeks later, the family was actually having a picnic under a waterfall right at Minnehaha Falls in Minneapolis, and he died during this family picnic. Now, not all of my patients die under waterfall, yeah, so this is like, sometimes it's very different, but I can choose what to present. You can read this up. We in the New York Times, the family allowed me to tell that story. What do I say to a dying child as a parent? So we can recommend to them, it's like, you will not be alone. You will not be in pain. And we will be okay. This is Jenny Harrington, who lost her son to leukemia. So this is curative care, palliative care. The answer is yes. So basically, what you're choosing is you're asking parents with children with serious illness, what class do you want to fly in? Do you want to fly economy, standard medical care, or do you want to fly business? You also have palliative care. Economy or business, that's the option. So I hope I could convince you that palliative care is awesome. It's appropriate at any age, at any stage. It is provided by an interdisciplinary team. It cannot be done just by physicians. Yeah, and you need to plan for the care in the hospital, but you must have a huge emphasis on the home care setting. How do you get them home? How, like when, where they live? And as I could convince you, hopefully, morphine midazolam, fentanyl midazolam does not shorten a child's life. Yeah, so we come in and ask, how can we help? And then we listen. I'm finishing up, second last slide here on this quote from Will Adair Rogers. Thank you very much for your attention. As you alluded, we're running a pain masterclass. It's a 7-day crash course in pediatric pain once a year. So it's just up the road. And we're going to Epic Pediatrics and tomorrow to teaching that. Thank you very much for your attention.
Thank you so much, Stefan. I know we're a little bit over time, so anybody that needs to go, please feel free. Stefan is with us here in this room for the next hour, and so we'll actually continue the conversation. But really, please do feel free, grab food, do whatever. Does somebody have a question here in the room that they'd like to ask? Yes.
Good morning.
How often are you and your team efficacious, successful on your first visit with the family versus allowing it time to digest, allowing your input presence to sink in, digest?
I think that's a great question. And this comes probably to the 1 hour answer, like, what is efficacious, right? Like, how do we define that the consult was successful? And because it's on the range from, I introduce myself, I'm being kicked out, to the family has identified this is the goals of care and we're going to implement them, right? As somewhere in the middle. So I think the answer is it depends. Because I think initially, like when programs are very early in the stage, then you're called in very, very late, right? That's okay, it's on the ICU. We had this child in liver failure for the last 6 weeks, and we're going to we just decided we're going to extubate in 2 hours. Could you do a palliative care consult? Yeah, it's terrible, right? This kid has been here for 6 weeks. So but earlier we get in and we just introduce ourselves, and then we if we know we have time, it's much easier to sort of do the things rather than in there. So happy to do that more, because it very much defines, it's like, what is a successful consult? Is just introducing and not being kicked out, is that success? Yeah. Is it that we can improve the pain and symptom management within that hour? Is that the success? Is that the families actually say, which I've had done at this discussion 3 days ago, the parents looked at each other. We have never, like when I asked, what's the worst case scenario? We've never asked this. And this was a kid with a brain tumor, which is now who was diagnosed 7 years ago. Yeah, now sort of had to relapse. And so it's sort of like, I think it's a question of definition. And we show up, look good, want to be and see, how can we help? How can I help you as an attending or as a clinician? How can
I think, Stefan, what you're alluding to there is we almost always can help some. We can help more if we're involved earlier, right? And have a little bit more time that we can be in developing relationships, etc. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.